Okay, any questions from immunizations or any other things that we have covered previously? Nothing? No. Okay, so we're going to finish up with our last section here. We're going to do a little bit of geriatrics and talk about prescription writing. You guys will probably never actually have to write a handwritten prescription ever, but in the off chance you have a computer system go down or something like that, it's good to know the necessities of what needs to be on those little pieces of paper. First off, we'll cover a little bit about geriatrics. You guys have covered this in other classes, so this will be kind of reiterating kind of some of the key points about it. We'll talk about some specific examples of drugs you should be careful of in elderly patients. And what do you call that list of drugs that you should watch out for? The Beers list, yes. It's not the thing they have, like the tap list or anything like that. It's actually. Oh, it's also appropriate. Did you guys see the announcement I put out about my natural substances? Yeah, guess what today is? That's all you need to say. Anywho, there's like one person who's like, huh? What's today? Thursday? Thursday. Okay, anyway, so geriatrics. So we know we have an aging population. People are getting older all the time. You guys are actually doing it right now if you didn't know. You have that slow creep towards our mortality. We have quite a few elderly individuals, and so a lot of your patients, unless you work specifically in peds or something, you're going to be dealing with U.S. life expectancy around 79 years of age or so, and so we'll see how that kind of changes because we have pretty poor diets, but medical advances and kind of balance that out. So anywho, it's really important to do kind of full assessments for your geriatric patients, because what ends up happening with a lot of these patients is they undergo what we call polypharmacy. Do you guys know what polypharmacy is? Yeah, lots and lots of drugs, right? And how do they end up with so many drugs on their list?
Lots of doctors.
Lots of doctors is one definitely good reason, right? So they go to Dr. A, they say, you need to be on this, right? And then they go to Dr. B, some other specialist, and they say, you should be on this drug. And then finally they come back to you, and they have like 15 drugs, and you're like, well, I don't want to stop any of these because I don't want to step on the toes of any other providers, right? And so people have these lists perpetuated kind of ad infinitum until the patient, usually succumbs to that. And so we'll find that there's a lot of issues with that, obviously, especially when you get this like kind of sick cycle where they have an adverse effect from this one drug, and so you go to see someone else about it, and they say, well, you should probably need to be on this other drug, and so you get another drug to treat that adverse effect, and kind of goes on pretty cyclically in that manner. But anyway, so it's important to kind of do these full assessments on your patients, including like, can they even take the medications that you're prescribing for them, right? Do they have the actual functional ability to remember to take them or to even see what's on the label, things like that. Because we need to make sure that our patients, if we're going to prescribe things, they can actually take them appropriately. Usually it requires a good interdisciplinary team, so getting people like nutritionists on board, having your pharmacist on board, you guys as the providers, kind of make sure you're consulting everyone to make sure you're doing right by your patients. So anywho, obviously, they have various levels of activities of daily living, so things like can they bathe themselves, are they actually able to get out of the house, all of these things. Obviously medications can have a big effect on these as well. So for instance, a lot of sedatives and things that can cause sedation are going to maybe inhibit their ability to do some of these, right? Some of them drugs may actually give them functional ability, right? So if they can have their CHF kind of properly managed, they might be able to be a little bit more functional and get some of these things done. But anyway, so again, these are other things we're going to be assessing for, like, can the patient really just take care of themselves, or just how active they can be. The nutrition assessment of a lot of these different types of kind of geriatric assessments is important because, one, why do we worry about their nutrition? Keeps them healthier, right? So, yep, you want to eat and make sure you don't have malnourishment or losing weight and things like that. What other kinds of things about their diet can affect medications? Yep, absorption could be a big one, right? So what do you tell a lot of older ladies to drink? A lot of milk, right? Because you want them to get calcium, so you tell them to drink milk. Guess what milk binds to? Lots of drugs like iron combined to fluoroquinolones, combined to your Synthroid, things like that. So you think about things like drug-food interactions. You worry about absorption of some medications. If they have a history of AFib, what type of drug might they be on to prevent stroke? Anticoagulant like? Yeah, so they might be on Xarelto, right, if you have some of the newer drugs. But Coumadin is going to be one of the big ones, right? And so Coumadin or warfarin. And what big food interaction does Coumadin have? Not so much grapefruit. Not potassium. Vitamin K, yeah. Remember, vitamin K is a huge one for that. Everyone should have been shouting out vitamin K, right? That's one thing you need to know about warfarin. You guys are like, no, I'll never use warfarin. I'm going to use these newer drugs I can't reverse, and then my patients bleed out. They'll die. I am not joking about that. No, to tell you the truth, like my mom, she developed AFib, and so they actually put her on Eliquis, which is the apixaban. It's a 10A inhibitor, right? And so it's great because what do you not have to monitor on Eliquis? The INR, right? So you don't have to go in for frequent checks. You don't have to really adjust the dose so much. She ended up having some pretty significant hematuria associated with that, you know, but you have to end up balancing out, okay, well, why is she having this hematuria? Is it specifically the drug? Is she having other things that are going on? And so, I mean, she's been having all this bleeding going on for, you know, several months. Eventually, they ended up finding a stone, ended up going in and do lithotripsy, getting rid of that, but still is having a lot of hematuria associated with it. And then, you know, the other thing is, like, you know, she has, you know, kind of functional issues with her gait, and so she has bad knees, and so if she falls, she's got a huge head bruise, right? And so you have to think about these drugs that you can't really reverse that well. And so fortunately for her, she kind of went off of it for about 2 weeks or so at the direction of her cardiologist, had to do some kind of repair of that kind of some of the bladder cells and things like that. And so now she's not having any more bleeding, but it's led to things like her needing iron transfusions because she was not actually getting her hemoglobin recovered very well, right? She was not absorbing her iron very well. So again, lots of different things that can have, you know, kind of functional effects on your patients or on your family members. But vitamin K with warfarin is a really big deal because, again, if they get too little vitamin K while they're on warfarin, what could happen? They could bleed, right? Absolutely. So if they get too much vitamin K, doesn't work as well, right? Because you're making too many clotting factors. Your INR is going to go back down to 1, and you're going to see that they could be more at risk for clot. So it's important that, you know, you counsel patients on things like, you know, okay, you can have vitamin K, you just have to be consistent about it, right? Because especially when you're going into some of these more kind of rural areas, like I grew up in Putnam County, and I did my first kind of ambulatory rotation in school at their anti-coag clinic in Palaca. And what do you eat a lot of when you live in Palaca? Collard greens, turnip greens, spinach, all that kind of good stuff. Most of it homegrown, you know, so it's important to make sure that you tell them just be consistent with it. Don't go on a crazy spinach diet where you're having, you know, 3 salads every single day for a week and then stop doing it the next week, right? You have to be consistent with a lot of these things. So these are all kind of things you have to consider. Also think about other problems that can pop up. You know, a lot of these patients have chronic pain issues, and so we put them on what type of drugs for their chronic pain? Opioids. And what do opioids do to your bowels? Yeah, stop them, right? So yeah, so opioid-induced constipation is a huge issue, right? Because constipation itself is, you know, kind of detrimental to your quality of life. Never underestimate the value of a good poop. My 10-month-old could definitely tell you that. But my wife, who, you know, did a lot of hospice training, you know, that was her second-year residency, was just in pain management at the VA. You'd have these patients who were, you know, in hospice, end of life, and they couldn't figure out how to get their pain under control. The patient was just obviously uncomfortable, and for a lot of them who couldn't really vocalize what was going on, you know, they put them on a good laxative regimen, they'd poop, and all of a sudden, like, their vital signs would get back to normal. They'd feel so much better, and so, you know, there's a lot of things you have to consider with their diet and with the other medications and how that can affect that. So also other things like, you know, they can affect their nutrition, like, you know, if they don't have good financial resources in order to get food. You think about, like, you know, potential changes for things like Meals on Wheels, right? So that could be potentially, you know, not as well funded in the future, you know, depending on the political climate. That could affect your patients as well. Not making a stance either way, just saying that could be a change that happens. So so again, it's important to ask about the food that they're intaking, make sure they're getting enough fluid. If they're not getting enough fluid, what could happen? Dehydration, which could lead to hypotension would be a good one, right? Which could lead to potential for, yeah, so you see renal failure, could lead to orthostatic hypotension. You see falls associated with that. So it's important to make sure they stay hydrated. Specifically for, like, from a drug standpoint, yeah, the renal function is a huge thing. We have a lot of patients who end up coming from, or they get brought into the ER from the, you know, assisted living facilities where they don't really get as good of, you know, attention paid to them, and they get dehydrated. Their drug levels build up of things that are renally eliminated, and they come to us for toxicity, right? So it's a big thing to watch out for, make sure they get enough fluid in. Also ask about other vitamins and supplements. You know, a lot of patients will not consider things like the vitamins or the over-the-counter kind of products they take as part of their medication list. So you have to ask specifically what type of vitamins, what type of herbal supplements are you taking. And also you can give them the amounts they're taking as well. Think about things like grapefruit juice. Like, that can be a huge thing that can affect, what does that affect? Statins. Okay, how can it affect statins? SIP, what does it do? can be an inhibitor, yeah. So you can see levels build up of your statins, and it affects that PGP as well, and that inhibits that PGP, which is that efflux pump. So you're seeing levels build up. So again, that could be a big part of their diet. Like they love their grapefruit juice in the morning, and that can be playing a major role. So you may decide to choose different medications, right? So using something like rosuvastatin or Crestor instead of simvastatin, because it will lack that interaction. So again, ask about you're looking at things like their dentition to make sure they're actually able to consume their food appropriately. You also have to consider like can they swallow their medications? Like are they having dysphagia secondary to like a stroke or something like that, where they're not really able to get their medications appropriately. All these things you're going to be asking about. So also ask about alcohol intake. This could be playing a big role. So especially if you have like chronic alcoholics, like they're obviously going to have poor
Liver function.
Yeah, liver function can be taking a hit. They may have like some degree of cirrhosis, so they may have impaired metabolism there. Also, ethanol itself can be affecting what type of other medications, kind of acutely. Maybe antidepressant, yeah, if you have like more sedating antidepressants, antipsychotics, you can have some interactions there. Obviously, so alcohol itself can obviously affect their kind of psychiatric conditions as well, but just acutely, if I'm taking a lot of sedative medications or medications that can cause sedation, that will be synergistic with ethanol, right? So think about benzodiazepines, think about even your first generation antihistamines, things like that can all cause sedation. Yeah, also be looking for kind of changes in weight over time. You may need to adjust doses of the medications if you're losing a lot of weight or gaining a lot of weight, etc. So those are all things you're going to be looking for. So also be checking, kind of consistently look at laboratory tests. This is another huge thing that a lot of providers may not do, where you'll see that they'll kind of put a patient on a medication, they'll keep them on a regimen, and they'll be on that regimen for the next 15, 20 years, right? So this is the big thing I saw a lot with theophylline, what do you use theophylline for? Yeah, it's used mostly for COPD, sometimes for asthma occasionally, but it's an older drug. We don't like to use it because it is pretty toxic. So we'd have patients who get put on that, and do you guys know how theophylline is eliminated? Through the kidneys, right? So little old lady get put on theophylline for COPD. She'd be on that for years and years and years. Never adjust a dose based on renal function. Comes in with levels that are sky high. End up seizing.
Is there some like standard practice pronouncing these drugs? Because every single time in my head I like pronounce a drug, it's actually pronounced differently.
It's like theophylline.
Theophylline, yeah.
Mm-hmm.
Or clopidogrel.
Mm-hmm. Clopidogrel is pretty good.
So, is there any like convention of like the vowels? Are there short vowels, long vowels?
I've never been asked that question, and that is a very good one.
Yeah.
I don't know of any standard. You might be able to do like, when you type the word into Google, they'll have like a little translate button, or not translate, but say it out loud button. Those are usually pretty good for the most part.
Okay.
You'll find that even healthcare providers will say drugs very incorrectly. I like some of the stuff that patients will say when they come up though. I had one guy that came up and he was like, where can I find the acetaminophen? And I was like, what are you saying? And he was like, for a headache. I was like, oh, acetaminophen. Okay, gotcha. You can find that. Had one patient come up, ask for their CLA. You know what CLA is? Their potassium chloride. They got their KCl, right? I heard Huctaz for HCTZ. It's a pretty good one. And then if you ever hear someone say peanut butter balls, phenobarbital. Yes. So that's a very good question. Usually Google's pretty good at that. So if you just hit the little pronounce button, that'll usually give you at least a good example. But a lot of these newer like monoclonal antibodies, like there is many different ways for a lot of people to say that. So you may hear someone say it differently, and it's okay. Yeah. Yeah. Like for instance, like ketorolac or Toradol. Ketorolac is actually the correct way to pronounce it. But no one ever says that. You sound kind of goofy saying it. So we just say, I'll say ketorolac. Or just say Toradol. It's easier. The brand name is usually much easier to pronounce, probably for a reason. So anyway, so again, make sure you check kind of baseline labs. Make sure you're checking consistently, as time goes on, to look for any kind of abnormal trends, especially things like liver function. When you're considering drugs like statins and things like that, it can have effects on, causes hepatotoxicity. Check a baseline, checking at 3 to 6 months, and then just periodically, maybe once a year, checking up on these values So liver function, kidney function are the big ones. Obviously, electrolytes can be playing a big role here. So for instance, if you're having some degree of renal dysfunction, you can have their potassium levels start to climb up. That can affect drugs like digoxin. If they're on antiepileptics, things like carbamazepine can affect sodium. So again, you want to be checking for trends in all these things over time. Obviously, certain medications can affect your glucose, so especially if they have diabetes and you're worried about drugs actually increasing that, that can be problematic as well. Those are the big things to watch out. Also, like in the instance of talking about my mom, looking at hemoglobin over time, right? She knows she's having this hematuria, needed to have serial hemoglobins being done. That actually prevented her from having her actual knee replacement done. You see how these things kind of beget one another, where she has gait issues because she has bad knees and she can't get her surgery done because her hemoglobin is too low because she's bleeding from the aliquis. And these other bladder issues she has, and you see how it's kind of all kind of pile up on one another. And now she's like on 10 different medications just to try to manage all of that. So again, it's not a lot of fun from that standpoint. So again, polypharmacy is going to be considered to be kind of the use of 5 or more medications at any given time. I've personally seen patients on 12, 15 medications. It sounds like an exaggeration, but it's legitimately that's how many medications they just take on a day-to-day basis. Some of the reasons why that is that they're living longer. They have longer time to get more diseases and treatments for those. So more chronic illnesses, longer lifespan, and then also looking at just evidence-based guidelines. So as guidelines develop, there may be new recommendations for saying okay, well now you really should be on a statin, you really should be on a beta blocker, you really should be on aspirin, you really should be on all these different medications. You can see how the list can kind of pile up pretty quickly just based on doing what's best practice. So again, if you had a patient who had osteoporosis, osteoarthritis, they had type 2 diabetes, hypertension, COPD, again, that is very, very possible. You'll see lots of patients like that. Again, they could be on 12 different medications, and it can be very confusing because you're taking it, say, 5 times a day, right? So different medications. This one's 3 times a day. This one's twice a day. This one's just once a day. And like I said, I can barely even take a multivitamin 1 time a day. So imagine these older patients who have memory impairment, have sight impairment, are trying for them to keep up. It's very, very difficult. And so the other thing is when patients come into the hospital, how many patients come into the hospital and you say, okay, I'm gonna DC 3 of these meds when they get discharged? No, never. You get more meds added on, if anything, right? Which is very problematic. So especially if you have the doc who's ordering it from the hospital is not the same doc they're seeing on the outside, and they have different specialists, and you can see how no one really wants to step on each other's toes from that standpoint. So these meds just keep getting added on and on and on. So it's nice for someone to have the kind of a rational, it's not the commercials, stop the madness. Someone needs to do that, right? And hopefully that's you guys, and say okay, we're going to stop all these medications or stop 3 of these because these aren't really doing any good, or they're directly competing with another drug, right? So obviously consequences here, the big one's going to be adverse drug reactions. As you increase the number of meds you're going to be taking, you're just increasing your risk for having these adverse drug reactions. Falls are a huge thing. So I mentioned my mom. She is a nurse. My dad's a CRNA, so they are healthcare providers. Do you think that they would be able to handle most medical situations that happen, right? So she ended up having a fall in the bathroom while in the aliquis, had a huge area of ecchymosis on her head. And you would think at that point, what would you do with her? Go to the hospital, perhaps, maybe the ER, for perhaps she's having a brain bleed, right? They said, nah, we're just going to do neurochecks here at the house and then just keep her here. And so, of course, my sister, she's a nurse practitioner, and when she heard about it, she was giving them verbal beratement on the phone for at least an hour or 2, and then I got my turn to do it as well. But right, so falls are a huge thing, right? So she could have very easily had a serious brain bleed, could have died from that, could have had seizures, etc. But falls are a huge thing, especially if they have any kind of fractures associated with that. Huge impact on their quality of life and their ability to get around. Hypotension can be related back to this. So if they're on a lot of antihypertensives or if they're dehydrated, that could be affecting that. Just decreased muscle stability, altermentation, confusion, all these things can be affecting that. And also when you have polypharmacy, you're decreasing your chances of having a compliant patient, right? The more complicated their med regimen gets, the more adverse reactions they're experiencing, the more reasons they have to maybe not take those medications like they should. So some of the things that can lead to that decreased compliance, one, if it's a very complex dosing schedule, so this is why we like to give things as infrequently as possible, right? So think back to like, those patients who are on, who had HIV, they're on antiretroviral therapy back in the, like in the 80s, right, early 90s or somewhere, all these drugs are coming out. If you watch videos of that, they'll be on, just dozens and dozens of pills they're taking a day at all these various times. It's very hard to keep up with, especially for a geriatric patient. So the more complex it is, more likely they are to not do it well, especially multiple medications. And then also the economics of it play into it, right? So if I prescribe you the latest, greatest medication that's brand name only, it's going to be pretty expensive for the most part. And then depending on what their insurance coverage is, may or may not be something they want to cover, okay? So if they cannot afford it, they're obviously not going to take it. Or you may find that they'll kind of do this intelligent non-compliance, where they'll say like, well, I'll tell the doc or I'll tell the provider I'm taking it like I'm supposed to, but I can only afford this, every other month. So I'm going to take one every other day, right? So they'll do things like that where they're not getting their full dose like they should. Visual impairment is going to be a huge thing as well. I had this one lady I remember who came up to I was doing my ambulatory rotation in pharmacy school, and this lady came up, and I mean she could not see more than an inch in front of her, but she had like 12 different medications she was on. She had all these different symbols that were on top of the bottles. She's like, hey, make sure you give me the tops back so I can put them on the right medications. And I was like, you really remember all these different symbols? There's like a black circle here and a blue triangle here and a pink square. And she's like, yeah, I know every single one of them. And I was like, all right, so what's this? It's like, what's this? Yellow squiggly line. Oh, that's my metoprolol. Okay, what's this one? She knew every single one of them. So, but she was able to use that at least with those large symbols. But if you asked her to read the actual label on the bottle, never would have been able to do it. So some people have some workarounds for that. Some don't. And they're just kind of guessing at it. Other issues you can see, decreased swallowing ability, may not be able to take the medication as well. Although some of these patients may have poor IV access, which they are frequent sticks, so that can be an issue where you're just not able to give them medications like you need to. Obviously, there's other things you can do, things like IO routes and whatnot, but we have to use the veins if we can. And then just a patient willingness to adhere to treatment. So why would a patient just say, screw it, I just don't want to take these meds anymore?
Suicidal.
So suicidal, perhaps? Or maybe they'll take all my meds, if that's the case. Some other reasons. So yeah, so side effects could be a good one. There's just like, hey, I just don't want to deal with these side effects anymore. It's a huge one. Think about end-of-life patients as well, right? So at a certain point, you're not going to be able to necessarily extend their quantity of life any further with the medications you're giving. So maybe getting off the meds can actually improve their quality of life. That could be a good discussion to have with patients, especially towards the end of life, where you can say, hey, do you even want to be taking these anymore? Like, if you're 85 years old and you have 6 months left to live and you have this horrible cancer, do you really need to take a statin? Is like a heart attack really going to take you out at this point? Probably not, right? So those are kind of the discussions you should have with patients, and be pretty frank with them. Like, if they're not going to take it, they should at least be honest with you and not think that they're going to, get your disappointment or something by not taking the med that you prescribed. So again, end of life kind of being that stage where patients have less than 6 months to live, and you really need to prioritize those patients as they get older to see what their kind of priorities are, what's important to them, because that way you can kind of tailor things to make sure they're more likely to be compliant. Because obviously, early on in the course of the disease, we're trying to extend life as much as possible, but obviously they can have negative effects on their quality of life due to side effects and et cetera. It can be a very big economic kind of impact on them as well, which can be affecting their quality of life. But again, towards the end, you're getting more towards the palliative treatment, where you're not necessarily looking to extend that quantity of life, but it's more just about quality of life, looking to do things like pain control, especially if they're like, end-stage COPD patients who have really horrible dyspnea. Like, what might we give them? We give them oxygen, sure. What else could I give them? Maybe. But we give them morphine in a lot of cases, right? So really bad end-of-life COPD patients, we actually give them morphine because that actually helps to blunt that response to that increased CO2 that they have, right? So that way it really kind of relaxes their dyspnea. They're not breathing any better. We're not actually helping them to extend their life at all, but we're at least letting them be more comfortable, right? So that's kind of the goal of a lot of that kind of palliative treatment. So it's really kind of like my wife's kind of standpoint. I like to reverse all that kind of stuff. So we're kind of a good mix from that standpoint. Anywho, so just normal age-related changes that you'll find with patients. Again, cardiac function is going to go down over time. You're going to find higher systolic arterial pressures. Left ventricular function is going to be going down over time, just reduced heart rate in general. And the renal function is one of the really big ones that, again, does not get a lot of attention in some cases. It can lead to some big issues. But obviously, if we're having decreased renal mass, blood flow to the kidneys, GFR is just going to be going down just in general as you kind of wear it out. Obviously, certain disease states can speed up this process, so it's a big one that can affect your GFR over time. Blood pressure, yeah, so hypertension can do this. What else? It's the other big diabetes. Yeah, diabetes is huge, right? So much sugar in the blood, just kind of shredding those glomerulus, like that's going to lead to kind of a more rapid decline in renal function as well. So this is why we want to get all these other things in check and under control in order to help kind of preserve our organ function as best we can. But you'll also see that they're less able to kind of manage their acid-base status, more likely to have kind of big swings if they get septic or if they have drug toxicity, things like that. They're much more likely to be acidotic and be in a bad state. But you can see here, just kind of as normal decline already happens. Sorry for some of us that are already over the age of 30. We're already declining as it is. So again, we're all shuffling closer to our mortality all the time, but some a little bit faster than others. Okay, so some things that can happen, just normal age-related changes with the GI tract. Normally, you'll find that absorption of medications normally stays pretty consistent for the most part. It's usually other changes that are affecting that. So things like their diet, if you have drugs that are binding them up. You typically will see decreased motility, which can affect how quickly drugs are being absorbed. But think about things like the fact that if they're on opioids, they're going to have slow GI motility. They may have delayed absorption of medications. May not really see those kind of peak effects like you'd expect. That can all be affecting the absorption. But again, think about other things like, are they on laxatives? Are they on antacids? Like, how can antacids affect absorption of medications? Calcium can bind to stuff, absolutely. Yeah, so weak acids, if you increase the pH of the stomach and of the small intestine, they may not be able to be absorbed as well, right? So if it gets into unlike solutions, they don't like to be absorbed. So that can be affecting that. Diabetics especially can have impaired gastric emptying, especially the gastroparesis. So that can be affecting absorption of medications. But again, always ask about OTC stuff, ask about herbal supplements, ask about things they may not think about answering when you get a full kind of medication list. Now, drug distribution does typically change pretty significantly for these older patients, depending on kind of what, kind of how they've been progressing. Typically, you're going to see reduced lean body mass, so muscle mass is going to be going down over time, and typically you're going to end up seeing higher amounts of adipose tissue, right? So more fat, less muscle, and total reduced body water. Okay, so how might you think that will affect, say, a lipophilic medication? What does that do to its volume of distribution? You go up, right? So if you have more fat tissue, if you have lipophilic medication, it's going to want to distribute out to that tissue more, right? So it's going to distribute further, have a higher volume of distribution. So your blood levels will end up dropping, right? Because this is all distributing out to the tissues. Similar thing for the hydrophilic medications, they're going to have a reduced volume of distribution, right? More of it's going to be staying around that central circulation because you have less water for it to kind of distribute out to out there. And you can see some of those changes here kind of on average with someone who's say 20 to 30 years old versus someone who's 60 to 80. Again, looking at the body fat's going up, lean body mass is going down, and that even things like albumin typically will be going down over time. And albumin's important because why? Binds a lot of medications, right? So think about drugs like phenytoin, which says 90% protein bound. Only that 10% that's unbound is the one that's physiologically active, right? It's one that's actually causing it's both side effects and therapeutic effects. If I'm decreasing the amount of albumin that I have available, more of that drug is not being bound up by it, and so I have a higher free fraction, more likely to see toxicity. So you can see how these things, if you don't track it over time, can lead to problems. So again, decreased albumin in general, a lot of this could be related back to nutritional status. So they're not getting fed well. Obviously, they're not going to be producing a lot of protein, so albumin is going to go down. That is going to be mainly affecting things like weak acids and whatnot. You actually have increases in some proteins, so things like alpha acid glycoprotein actually increase therapeutically. It doesn't really come up all that too frequently, but eventually it's going to end up affecting that free fraction of drug. So if albumin goes down, you have a highly protein-bound drug. More of it's free, more of it's going to be active to either cause therapeutic effects or toxic effects. Yes, for the albumin. Yep. Obviously, drug clearance in the kidney is going to go down over time, so you have reduced renal function. And sometimes estimating what their actual renal function is can be difficult, right? So we mentioned the muscle mass goes down, and where do we get our creatinine from? Muscles, right? So you may have a patient who, say, is 90-year-old little old lady who comes in, and her creatinine is 0.8. And I look at her and I go, I know your renal function isn't that good. Right? So in a lot of cases, because she does not have enough muscle mass to really produce that creatinine, she is going to be overestimating what her actual renal function is if I did the calculations. And I'll show you some of those in just a few minutes. Also think about things like, do they have an amputation? They have below the knee amputations, obviously they have less muscle, so that would, and again, overestimate what their renal function is going to be, okay? So you have to take that into account. Kind of a general rule of thumb, what I do for these older patients, especially when they're in the 80s to 90s kind of age range, if they have a creatinine that's less than 1, I just round up to 1 when I do my calculations for GFR. Just say, hey, just round up to 1. That's usually a little bit better estimation of what their actual renal function is. And what else could I look at to see what how their kidneys are working? Urine output, yeah, urine output's a good one. Usually, we use that a lot for kids as well, but I like to use urine output in adult patients. Usually about 0.5 to 1 mLs per kilo per hour is generally a pretty good amount, right? So especially like in the ICUs and they have Foley's, you can get pretty accurate estimates of what their urine output is like. But 0.5 to 1 mLs per kilo per hour is a good number to look for. But again, if their renal function is going down, they're going to have increased half-life of certain drugs, increased risk of these toxic concentrations. And again, this is very much affected by the hydration status. So if they come in dehydrated, they're not going to be perfusing the kidneys as well, not clearing those drugs as well. So very frequently, you can see how the serum creatinine is playing a role here. So the Cockcroft-Gault equation is very frequently used for most adult patients. You don't use this in the extremes of age in a lot of cases, but just to give you an example, you can see how both weight is affecting creatinine clearance. So as their weight goes up, typically they have more muscle mass or producing more creatinine. The renal function is improving. Their age is affecting this as well. So as your patients get older, what is that doing to your creatinine clearance? Yeah, it's decreasing, right? Because that difference is going to be smaller there. And then you're factoring in the serum creatinine. So, you see that there in the denominator. So as that number goes up, obviously that's dropping your creatinine clearance as well. But if that number is falsely low, either due to the fact they have a small amount of muscle mass or due to like missing limbs, that could be affecting that and be falsely overestimating what their actual renal function is. Okay, so then I'm dosing medications at larger doses more frequently than I really should be. And why do I do that 0.85 for women?
Less muscle.
Yeah, in general, they have less muscle mass, and so I can take that number, which is, that would be for a male patient, that would be their creatinine clearance. For female, I would just multiply by 0.85. Very frequently, what we do for older patients, and again, there's lots of different calculations, but we do this MDRD equation. And so you can see here it's a lot more complicated. It'll actually factor in things like, if the subject is black, that can have some effects on their ability to generate creatinine and whatnot, or the renal function. Age is factored in here. It's more complicated, but again, you can look online and plug them into the calculators to get an estimate of what the renal function is. So again, liver clearance of drugs can be affected by the actual blood flow. So if you have impaired flow due to things like CHF or due to liver dysfunction, you're not going to be able to clear that drug as quickly, so that can extend the half-life. And in general, you're going to find that you may have some diminishment in function of things like CYP450, but for the most part, those are going to stay relatively active as compared to your decline, say, like in renal function. But most of the decrease in metabolism comes from the impaired liver blood flow. So those are pharmacokinetic changes for the most part, but looking at the pharmacodynamic changes, the question is like, are these geriatric patients more sensitive to medications, right? Are they just getting more bang for your buck, essentially, from these doses of medications? A lot of it goes back to the ultrapharmacokinetics. So if they are, have extended half-lives, they're not clearing as well. Obviously, the drugs sticking around for longer, have higher levels, more likely to see these effects, more likely to see toxicity. But in a lot of cases, it's also going to be related back to their kind of homeostatic kind of compensation processes. And as those start to fail, you're going to see more of this kind of drug response. So that's where you see a lot of orthostatic hypotension leading to dizziness and falls and whatnot. Comes about from those sort of kind of changes. But again, cardiac output, their postural hypotension, all those things are affecting this. Even things like fasting blood glucose is going to be affecting how well things like your diabetic medications are going to be working. So we'll look at some specific drug class examples of how elderly patients should be really kind of be very careful with these patients and make sure you're kind of monitoring them with an extra degree of caution. So sedative hypnotics are a huge one, right? We don't like to give a lot of sedative hypnotic agents to our older patients. So what are some examples of sedative hypnotics? Yeah, so benzodiazepines like lorazepam, things like that. Peanut butter balls like our barbiturates, absolutely. Any other drugs you think of? Think about things like first-generation antihistamines, right? Think about things like diphenhydramine or chlorpheniramine. Like that can be very sedating for these patients. Think about muscle relaxants, right? Think about things like your flexorils and your scalaxins and things like that. They're also causing CNS depression. Ethanol is going to be involved in this category as well, especially if they're self-medicating for some things. So with a lot of these agents, you can see half-lives being extended anywhere between 50 and 150%, depending on if it's renally cleared, if it's hepatically cleared. You can also see the accumulation of active metabolites, which can be problematic. So you see that with some of the benzodiazepines. And you guys remember which benzos I said are good for older patients? LOT, which stands for lorazepam, oxazepam, temazepam, and triazolam. Those are the main ones. Mainly because those are going to be more water-soluble agents. They don't really accumulate in the fat tissue as well. They also don't have active metabolites for the most part, and they're going to be more easily cleared, right? So again, active metabolites also going to build up in the system, so that's why we try to avoid those as best we can. So really, we just don't want to have a really kind of extended half-life for these patients because they're going to stick around too long. They're going to get dizzy. They're going to get more likely to have falls, things like that. So also, it's hard to say like, well, is my patient's dementia getting worse, or is their Alzheimer's getting worse, or is it the medications that they're on? So sedatives can be a big player causing a lot of these effects here. Okay, so be very careful with those. Those are definitely on the Beers list. Looking at analgesics, as far as opioids go, for the most part, we try to use things that have no active metabolites as best we can. So a good example of this is morphine. Morphine undergoes glucuronide conjugation, so it has morphine 6-glucuronide, morphine 3-glucuronide, and both of those metabolites can build up in your elderly patients, right? Because those are renally cleared, that poor renal function, they're going to build up. So that can lead to more CNS and respiratory depressant effects. That can lead to other types of toxicity. So again, be very careful. Try to use things without active metabolites. So for some of these patients, things like a fentanyl patch is great because fentanyl does not have active metabolites. Has a relatively short half-life. Okay. So again, all choosing based on their altered kinetics here. Okay, looking at their antipsychotics and antidepressants, lithium can be a big one because this is so dependent on renal function to clear, and so this can have a lot of drug interactions. So for instance, if you have a patient who is on lithium long term and they start up an NSAID, what could that do to your levels? Should increase them, right? Because again, a lot of times these patients are dependent on those prostaglandins to keep renal blood flow going. If you give an NSAID, you're going to close up that afferent arterial, and you're going to decrease kidney flow. You're going to see accumulation of lithium. So that can be a big one. Lithium levels, they start to build up and cause lots of different neurotoxicity. So I really try to avoid using that as best we can. That's why you see a lot of other mood stabilizers like valproic acid or carbamazepine being used in lieu of lithium just due to those toxicities. As far as the antidepressants go, we really liked, and obviously, as patients get older, especially if you have, death of loved ones and things like that, depression is a huge thing that needs to be addressed in a lot of those patients. And so we like our SSRIs because those are much less toxic than things like your TCAs. Okay, TCAs, what kind of side effects would I expect to see from like a amitriptyline? Anticholinergic effects, right? So they're causing sedation from that standpoint. Urinary retention, which could be problematic, cause constipation. Those are all bad. Do you guys remember what it does to your blood pressure? Things like amitriptyline have alpha-1 antagonism, so that can actually cause hypotension, also leading to postural hypotension and dizziness and falls, right? So we don't like our TCAs for that patient group, but certainly our SSRIs are much safer. They have a much better therapeutic index from that standpoint, much less toxicity. So we like SSRIs for the patients. Even SNRIs can be useful as well. But again, avoid TCAs, avoid those monoamine oxidase inhibitors, because again, those are just too many drug interactions, too many side effects. The other thing is be very careful with antipsychotic agents in your elderly patients. A lot of times, if you have a patient, especially like they come into the hospital, the sun starts to go down, what do they start to do?
They get agitated.
Yeah, they get very agitated. It's called sundowning. They don't like to be in kind of unfamiliar environments. Your urge is to use some chemical sedation on them, right? And for some people. And a lot of times they'll try to use antipsychotics like haloperidol. They'll try to use things like some of the newer ones like Geodon and olanzapine, Zyprexa. They'll try to use those in order to sedate the patients in order to kind of get them to chill out. But there's actually black box warnings against that. There's been increased risk of mortality associated with that. So again, you really wanted to try to avoid using kind of any kind of mind-altering medications for these patients as best you can, because again, that can also kind of cloud their dimension. You don't really know what's what's worse. The patient actually getting worse, is that the medications we're giving them causing this. Go back to cardiovascular meds. Obviously, antihypertensives leading to hypotension. You can see issues like electrolyte imbalances with diuretics, things like that. And antiarrhythmics can be potentially problematic, especially when you have patients who have changes in electrolytes, especially due to renal function. There's a new drug we covered briefly in the antiarrhythmic section. It's called dofetilide, or Tikecin. You guys remember that one? Just remember what class of antiarrhythmic it was? Same class as amiodarone. Yeah, it's a class 3 antiarrhythmic. And so that drug is likely to, blocks potassium channels, so you can see things like QTc prolongation, risk for torsades, but it's really, really important, and they actually have very strict criteria. So this is one of the big things that my wife does when she's working over at ORMC with her patients. They'll do new start Tikecin. They'll start a patient on Tikecin in the hospital, because again, you are looking for dysrhythmias. But it's very, very particular. You have to make sure the potassium's in the right range, have to make sure the magnesium's in the right range, and if you don't follow that over time, patients can get out of whack. You can end up seeing arrhythmias associated with that. So it's really, really important, especially with antiarrhythmics, to watch their electrolytes, because that can be a big cause for dysrhythmias. Even certain ones like quinidine, lidocaine, procainamide, they can all have extended half-lives as well, due to things like hepatic or renal dysfunction. Okay, so again, we know that adverse drug reactions are going to increase with the number of meds that they're on. So a single medication, maybe say 10% risk for some sort of adverse drug reaction. By the time you get 10 medications, you're 100% likely to at least have some sort of adverse drug reaction. And keep in mind, your OTC and herbal medications are affecting this as well. I remember I had one patient who she was taking warfarin for her AFib, but she was getting older and she had some memory problems. So what do you take as an herbal supplement to help your memory? Take ginkgo. You can also take, yeah, ginseng can be another one. So she actually ended up taking ginseng. And one thing, if you ever take like an herbals class or learn more about them, is your G herbals for the most part, things like ginseng, ginkgo, they all have anticoagulant type of effects, right? So she ended up coming in with a massive head bleed. It's one of those ones where, like, you do the head CT, and if the pharmacist can look at it and say, like, that's bad, it was one of those kind of cases. Just massive amount of contrast is pooling up in her brain, and so she ended up dying from that, unfortunately. But it's one of those things where she had not really told any of her providers she was taking ginkgo, and so that led to that drug interaction, led to that bleed, or more likely to bleed. Can't say it's 100% the ginkgo, but again, that mixed with the Coumadin, definitely led to kind of a disastrous kind of situation. And her INR was normal. It was like 2.5, right? So it's definitely within the therapeutic range. Just that additional anticoagulant effect kind of pushed her over the edge. So also we can see some adverse drug reactions from prescriber errors. So what do you call that when you cause a problem for the patient? Iatrogenic, right? So we've got some iatrogenic issues. So if you don't take age-related changes into account, prescribe too big of a dose or too often, not taking organ changes into account, that can be on you. You see issues with patient compliance errors. So if they are have memory issues, they don't remember how often to take their medications, or they forget to take it. Things like that can lead to errors. Again, if you told a patient take 2 pills twice a day, how would you take that medication?
4 pills a day total.
Yeah, it's 4 pills a day total, right? Are you confident every patient you talk to will be able to figure that out?
No.
Some of them will take 1 pill in the morning, 1 pill at night, right? Because they say 2 pills, and I'm taking it twice a day, so I must take 1 in the morning, 1 at night, right? So again, make sure that they can teach back to you, right? Do that kind of teach back method where they say, okay, well, I told you how to take the medication, now you tell me how you're going to actually take it, right? That can be an important factor, but again, if memory is bad, they may not remember all of that. And again, seeing multiple providers, we kind of talked about that already. So lots of specialists can lead to big issues, just having the message kind of, the med list just increasing kind of exponentially. Also, some patients may not actually look at certain drugs as drugs. So have you guys ever heard of like BC powders or Goodies powders? Right, so those little sachets that have the powdered aspirin in it. I had plenty of aspirin toxicity that comes in, and they did not even realize that this stuff was actual medicine. Like they just thought it was just just a home remedy. Didn't think it was actually the same thing that they were taking for their heart. So every time they got a toothache, it would take a Goodies powder. More toothache, take another Goodies powder. So it's very easy for them to kind of dose stack, and them getting very, very toxic from that. Okay, so how should you be asking your patients about their medication list? There's a good kind of structured history. This is kind of just one example of kind of the questions you should be asking in order to make sure you're getting a full list of their medications. So obviously, are you using the drug as prescribed? Okay, again, a lot of patients are people pleasers, and they don't want to tell you that, hey, I'm not actually taking this like I'm supposed to, so they'll fib. You'll be like, yeah, I'm taking that every day, sure. Not really. So, again, be non-judgmental. Just say, hey, you can be honest with me. If you're not taking it, that's fine. We just need to kind of take that into account. Ask about side effects. They may not realize what they're experiencing is a side effect. So ask about things, are you feeling dizzy ever? Or are you feeling more tired? And things like that they may not associate with their medications. Ask about any deviations, why they're deviating, if at all. Ask about any other medications. What do some people do if they have family members that have other medications available? They'll take them, right? So they say, oh man, my friend Louise, she loves this stuff, so it's really great. She handed me a whole bunch of it to try out, and I'm taking that. They'll take each other's medications all day long. That's why we really recommend they take the full course of antibiotics, because otherwise you have a bunch of antibiotics laying around that people will take without really knowing what they're treating. So issues like that, and then obviously not over-the-counter medications. Certainly ask about those. As many homeopathic drugs, herbal medications, vitamins, anything that could be potentially interacting with some of our medications. That's why drugs belong to family members. Some people will try to go through other means in order to get their medications. So they may try to be ordering things online, say trying to get medications more cheaply, say like from Canada and places like that. May or may not be from a reputable source, so who knows what they're actually getting. Also, another thing to do is ask about the medication that they are no longer prescribed. A lot of cases, patients may not get the message that you said, hey, stop taking this medication, and they'll take it, continue on with it for years, right? And you never really realize it. So that can be an important question to ask as well. Also, check expiration dates. Make sure they're not taking stuff that's like, expired back in the 60s. So that way, at least they're getting active medication. Although most expiration dates are pretty bogus anyway. But at least ask about it. Okay. Ask about if they're able to take medications independently, or if they have someone who's helping them. Having caregivers help can be a big help for these patients who have memory impairment and things like that. We'll talk about like dosage systems, so the kind of like pill reminders and things like that can help them to know when to take medications and make sure they keep them on track. Also ask about what their technique is for taking certain medications. So for instance, this is a big one like COPD or asthma is like with their inhalers. As patients get older, they get osteoarthritis, their inhaler technique can kind of take a big hit. They can be less coordinated, and so they may be trying to use their inhaler and they're depressing it, and then they're taking their breath 2 minutes later, who knows what it is. But they could have pretty poor technique, so it's important to kind of reinforce that. That's why eye drops. Make sure they're you keeping it clean, not getting eye infections and stuff from those. All kinds of things you should be asking your patients. Just some examples of pill minders. There's probably even more advanced ones nowadays with app integration and Bluetooth connection, all kinds of good stuff. But these are the old school ones that we like to use occasionally. Okay, so again, there's lots of obstacles to compliance for your patients. I don't have like too much more to go. So you guys okay if I just skip the break and finish early? Okay. So anyway, so lots of obstacles to compliance, and one of them being medication cost. It's a huge issue. So looking at things like arthritis medications, like yeah, that new NSAID sounds great, but if I can get away with just using regular old ibuprofen, let's do that. It's a lot cheaper. Become familiar with things like the $4 list or the free medication list at different places, because you'll probably be sending a lot of your patients there in order to get those medications on the cheap. Okay, so think of the Walmart list and Publix and places like that. You'll have patients that go from, okay, well, I can get this medication really cheap at Walmart, then I'll go to CVS and get this one cheap, and then I go to the Publix and get this one. That becomes a problem on the pharmacist side, because then we don't have a full list of what the patient's taking. So they could be taking things that are completely antagonistic to one another, big drug interactions we would never see because our med list only has what they're filling there. Okay, it can be a big issue.
Is E-Force only for controlled substances?
E-Force is only for controlled substances. It'd be nice if we had like a universal list that we can see all the stuff that they're filling. That would be fantastic, but no one's going to pay for that. And
so you can't see who prescribed what or how long they've been taking it.
For E-Force, we can only see the who the prescriber was, where they filled it, and what the drug was. Yeah. So you can figure out who the prescriber was. So you can see they're going to a bunch of different docs and stuff like that. Oops. So anyway, so again, just make sure you're trying to use as as simple of a regimen as possible. This is where we like to use combination medications. So making sure that if you can take one pill instead of two, that's always going to be better for compliance. And just try to make things as simple as you can for your patients. Okay. So any questions on geriatrics? All right, moving on. We're going to talk a little bit about prescription writing. So prescriptions, we know they're either written, verbal, or electronic orders. from a practitioner to be either fulfilled by a pharmacist, or it could be a lab, or it could be anything like that. Who has prescribing authority here in Florida? Lots of people. MDs, DOs, obviously mid-levels like PAs and ARMPs, podiatrists, veterinarians, optometrists, anything like that can write for a prescription. Lots of other people as well. But it's important to know that there is some differences between state and federal laws, and obviously if you guys go to practice in another state, you may find some of this is going to be varying, but we're going to only be going over the Florida laws, okay, Florida and federal laws. Typically, if there are inconsistencies between state and federal, you go with whichever one is more strict. Right? So federal says, hey, you can write for 6 months of this drug, but the state says you can only write for 3, you only write for 3, right? Because that's the one you're kind of more beholden to at that point. So, and if it's not addressed in state law, then you fall back on the federal law. Okay, so if the feds say do this and the state says nothing about it, then you're fine to go with that standpoint. Okay. So, what are the basic prescription requirements that were listed in the Florida statutes? This is part of, you can go look up the statute and read through it if you ever need like some natural sleep remedies or something. Like it's, we had to go over this pretty extensively when we were in pharmacy school. But essentially, the basic requirements, and this is for non-controlled substances. You're going to find that controlled substances, as their name implies, there's going to be a lot more kind of restrictions associated with that. But if they're written or typed, they should be legible. I don't know why we had to put this into a law, but lots of people should go to jail for this one, because I've seen some really poorly written prescriptions. The name of the practitioner must be on there. Okay, the name and the strength of the drug being prescribed, and the quantity to actually dispense. That can be important because people kind of goof that up, and if the quantity doesn't actually match up with the directions, it may lead to a phone call. The directions for use, how the patient should do it. I really like to avoid putting uses directed on prescriptions. For some things that make sense. You know, if you have like a methylprednisolone dose pack where it tells you very strictly on the pack how to take it, that's one thing. Birth control makes pretty good sense, but otherwise, you know, you should write what the instructions are going to be, because if the patient forgets what you told them in the office and the bottle just says use as directed, they're not going to remember. They're done. Has to be dated. And then it should be signed by the prescriber on the date that it's issued. So there's no pre-signing prescriptions that you can just sign a bunch of them beforehand and then hand them out, right? We don't like to do that. They can be called in or communicated electronically, so you can fax them over. They can be phoned over to the pharmacy, and then once they're there, then they actually get reduced down to paper. So the pharmacist will write them down onto an actual script. At that point, then that's kind of your record for that. And then all prescriptions are only good for a year. So all of them are going to have an expiration date of a year. You're going to find the controls are a little different than that, but all of them are only good for 1 year. So you can put like 42 refills, but they're only good for a year.
For the written, or for the called in, do we ever get a record back, a written? So the pharmacist, if they wanted like a Z-Pack, could write themselves one easily.
Or they could just take it from the pharmacy if they wanted. I mean,
nobody's tracking. I mean, so controlled substances get tracked, but everything else, it doesn't really matter.
Yeah, pretty much. Yep. I mean, yeah, there's lots of unethical things that we could do. Like my sister's a nurse practitioner. I can call in and say like, hey, I'm calling in for this nurse practitioner.
Yeah.
Heather Wood, she wants me to have a Z-Pack, or
anybody can call it.
Yeah, anyone can call it.
And
Yeah.
it never gets back to the provider.
Right. It's one of those.
Need their NPI number probably. And good to go.
Yeah. So a lot of times you're looking at the provider, and so they'll ask for NPI numbers to look up a provider.
You can just Google that.
You can Google that. Sometimes we'll use like DEA number to look up providers, things like that. DEA is a little bit harder to find for the most part, but yeah. So yeah, there's lots of unscrupulous things that can go on. Yep. But again, that thriving Z-Pack black market has been on the downswing lately. And this is why we are so much more tight on our controlled substances for sure, though. Yep. Okay, so you can write for multiple non-controlled prescriptions on the same script. That's totally fine. Sometimes they get a little crowded, but just make sure to keep them kind of separated so we can read and see which ones are controlled. Which you should certainly keep your C2 or controlled substances on a separate prescription. C2s have to go by themselves though on a script, so you can't write for multiple C2s with, say, a benzodiazepine or something like that. What are some examples of C2s? Cocaine would be one, but hopefully you're not writing for a whole lot of cocaine. Amphetamines, yep. So all of your ADHD meds for the most part, except for like Strattera and whatnot, clonidine. What else? Yeah, and now the great majority of opioids, because hydrocodone used to be a C3, and then they got bumped up to a C2. So now most of your opioids are going to end up being C2s nowadays, so like fentanyl, hydromorphone, morphine, all that good stuff, all C2s now. Oxycodone being one of the bigger ones. Things like codeine are still, you know, be considered like a C5 in a lot of cases. Benzos are typically what schedule? Usually 4. Yeah, so usually C4. What are the different schedules of that? What are they in reference to? How do you determine a C2 from like a C4?
Federal government decided based on risk of dependence?
Yes, yeah. So it's all about abuse potential, about risk of dependence, and their accepted medical use, right? So things that have no acceptable medical use, yeah, those are Schedule 1. So like marijuana federally, still a C1, right? But you can have, you know, oxycodone being highly dependent, or you can, you know, high abuse potential, but it does have medical use, so you can consider that a C2, right? So it just kind of goes down in scale. So codeine being pretty wimpy, it's down on a C5, right? Anyway, so yeah, so C2s have to be on the script by themselves, but you could potentially write, you know, multiple, like, you know, a benzo and a phenobarb or something like that on the same script, and that would be okay. Okay, so here's an example of what a prescription would look like. I'm sure you guys have all seen a prescription before, but just so we're all on the same page. Some things on here are not actually required by law to be on here, but they are good practices anyway. So for instance, okay, we have John Doe Health Clinic, so we had the name of the practice, we had the name of the provider on here. Notice it has their license number, their MPI number, the DEA number. Do you guys know where DEA numbers come from? They come from the DEA store. You can go there and go purchase one. There's actually a method to the madness. It's kind of like your license, right? So the number on your license actually comes about like from your last name and different things, and then your date of birth. So there's actually a calculation you can do to back calculate to make sure it's an actual valid DEA number. I never actually learned how to do it. We never do it in the real world, but that was the initial intent. There's actually some method to the madness where you can go back and if someone gave you a bogus DEA number, you could find out and just say, okay, well, this is no good. But you know, eventually, you know, drug abusers are going to find out how to spoof that anyway, and it's no good. So this is why we usually use kind of multiple forms of identification, things like MPI, things like license number, in order to look that up. Again, have the actual address of the place and the phone numbers. That can be very useful to have. Notice here, you don't, like in the Florida statute, the patient's name was actually never on there. Things like the patient's date of birth was not on there as well. So those are obviously things you would like to include though on the prescription, because I don't know any pharmacist who's going to fill that without the actual patient name. No one who's going to be going to. Also, it's nice to put drug allergies on there as well, so we can actually go back and check that, or if it's a new patient to us, we can look at that. But again, not required for that. But you notice here, they put metformin, glucophage. You don't have to put the brand name, but that is helpful, just to make sure if we can read the metformin part. The strength of the tablets that we're getting, the number to dispense, so that's that number 100 there, and then the instructions for use. So take one daily. You could just put take one daily, and that could be the end of it, but it's also nice if you put indication. So you did for controlled diabetes. Metformin is a drug that you would, for the most part, only use for diabetes, but certainly if it's like for PCOS or things like that, it's good to have indications on there so we can know what you're specifically treating, right?
Are we supposed to write the 4 in metformin? Is it capitalized?
No, that was just like fake prescription. Right, I don't know. You mean the F on there?
Handwriting.
Oh yeah. That's the tall man lettering. I don't usually see it a lot for metformin. You guys know what tall man lettering is?
Is it the accented syllable? Oh, this is for court.
For court.
Yeah.
Oh,
How to pronounce it?
no, it's not pronunciation, unfortunately. So basically, tall man lettering is that if there are drugs that have very similar names to one another, they will capitalize certain letters to make sure that you don't mix them up. So good examples: hydroxyzine and hydralazine. So for those, like the oxy is capitalized in hydroxyzine, the ala is capitalized in hydralazine, so you don't get those mixed up, right? So one's for allergies, one's for blood pressure. Don't get that screwed up. So that's a big one. A lot of people get mixed up, and so that's why they do things like tall man lettering. It's why we separate them out and make sure they're not next to each other on the shelf. You know, things like that. Do you have a question, or anyone? Okay, so yeah, so it's just one of those things. And if you ever go to the ISMP, which is the Institute for Safe Medicine Practice, that's a very good website where you can get tips for, like, you know, medication safety in general. They talk a lot about things like, you know, how not to screw up with insulin, or how to, you know, use medications safely. It's good for both pharmacists and providers as well to kind of get an idea of what other people have done to screw up and how you can avoid those problems, right? So other things, you don't have to actually put a refill number on there. If there's no refills written, then we just assume it's a single fill, right? And then obviously it's signed here. Those scripts, you can have things like, electronically signed by, like we certainly do that for a lot of our non-controls. That's okay. Or if it was called over to us, we would just write down the providers, and again, no signature ever actually goes on there. Okay. Here's another example of kind of a pre-done script. In a lot of cases, you'll have multiple providers in a practice, and so you can just kind of check off whoever you are. Obviously, there's a lot of Dave Smiths that work at this place, but again, you just write, okay, this is the one that I am. Some of them will have kind of pre-done things like the quantity to dispense, things like that. You can just go and write in there or circle the number of refills. But again, you'll find lots of different ways that these prescriptions will be kind of done. Don't write prescriptions like this. I don't even know what that's for, but don't do it. You guys will probably never have to handwrite a prescription, but if you do, make it legible, please. I've seen some of your notes. Please. Just kidding. Okay. So then there's additional requirements for controlled substances, right? So obviously they're controlled, so they are going to be more at risk for abuse, and so we need to make sure we keep all these out of the hands of those dastardly drug doers. So what you need to have on a controlled prescription, this is any C2 through 5, you need the name, the full address of the patient, okay? So that way we can back check that to make sure, because very frequently we will check their IDs when they go to fill these medications to make sure they are who they say they are. Or if it's the owner of the animal, that should be on there. And then if it's for an animal, the species should be specified. So can you guys think of any examples where you'd fill a controlled substance for an animal? Ketamine? No, we're not usually filling ketamine through the pharmacy.
Controlled substances for dogs?
For an animal. So phenobarb is a very big one, right? So phenobarb for doggy seizures. Not just chasing rabbits in their dreams, they're seizing. Just kidding. Yeah, so phenobarb is a very common one that we'll see, but again, you should have the species and the animal, have the name of the actual owner on there, so that way that's who we can kind of check that against.
How do they check the patient? Bring your animal into the...
You don't have to bring your animal into it. But if it's so it's one of those things where, like, if you have a vet office that is frequently prescribing to you, you kind of get to know those things. Like, you know who the prescribers are in your area, and you kind of say, like, okay, this is Dr. So-and-so. They're writing for, Brutus, the Mastiffs, phenobarb. Like, this is, it's usually a pretty routine thing, right? Yeah, so you kind of get into habits like that. You kind of know things look legit or not. You can always call back to make sure it's actual, like, it's legitimate, right?
Do most people put a last name?
For the dog? Yeah, so when we put it into the pharmacy, we put the owner's last name as the dog's last name. So it's just what we do. That way we can look them up easier. Okay, so anyway, the full name and the address of the prescriber needs to be on the prescription along with the DEA number. There's no DEA number, we're not going to fill that script, right? So it needs to be there so we can back check that and make sure it's a legitimate provider who's going to be writing for that. And then you have to have the written and numerical quantity to dispense. Okay, so you have to actually have, it says 20 in letters and also the number, so that way we know specifically how much we're going to be dispensing. There's no kind of ambiguity about it, okay? And the Schedule 2 substances, they kind of are in their whole class of their own, essentially. So 3 through 5s can kind of be lumped in together as far as those kind of recommendations go. And then for C2s are even more strictly controlled. These have to be on paper, right? So C3, I could call in potentially to a pharmacy. I could fax over a prescription. For the C2s, they have to be on paper, have to be brought in by the patient, okay? Either written or typed, that's okay, but no electronic or verbal transmission that can happen there. And then you cannot write for refills for C2s, okay? You can write up to a 90-day supply, but you cannot have the refills. You can't write for oxycodone, 6 refills or something like that. It has to be just for whatever you're dispensing for that specific prescription. So this can be problematic, especially things that you're getting every single month. So think about like a lot of your ADHD meds. Basically what we'll do or what providers will do for a lot of cases is that they'll write 3 different scripts for like their Adderall, and they'll say do not fill until this date. And so you'll have a script that you can pick up today, you'll have another script you'll do a month from now, and then the third script you'll have 2 months from now. And so that is one way you can kind of keep the the patient from having to come back and see you every single month to get a new script for that. Also has to be hand signed by the provider. Okay, so it can be typed up, but it has to be hand signed by the provider. Okay, you're with me so far? Okay. For Schedule 3 through 5s, you can only have up to 5 refills. So you basically get a total of 6 months worth, and then after that point, the script is no longer good. So C3 through 5s are no good after 6 months. Okay, You can only write it for a 6-month supply for those meds. So basically, like the initial fill and then 5 refills are the max you can do for that. You can write for more than that, but the pharmacy is only going to give you that 6-month amount.
So each one of those though is it expires after a year.
So a non-controlled prescription is no good after a year, right? That's when they expire. These are going to be expiring after 6 months. Yep. And then they may be communicated by phone or facsimile or anything like that. So that's totally fine. So like your benzos, phenobarbs, things like that, they can be called over. Okay. You'll also find a lot of scripts will end up being printed out on counterfeit proof paper. So essentially, this is stuff that, like, if you were to photocopy it, you'd see all these kind of voids that would pop up on the actual the counterfeit one. So you'd see that, obviously, if you get a script like that, you're going to say, well, this is no good. I'm going to throw this out, right? So these are produced by specific vendors. So like whoever you're practicing at, they will order these specifically. Usually they'll order them so it has like your name on it and all that kind of good stuff. And they are going to have a serial number associated with it as well. So you can actually go back and track down where that script actually came from. So again, these are going to be used for those controlled substances that are not electronically transmitted. So a good example of this is like over at Nemours, like in our ED. All of our regular scripts that are non-controlled come out on regular white paper that we hand over to the patients. They can be electronically signed. We said that, okay, for all of our controlled substances, they will always come out on the counterfeit proof paper. And then the C2s have to be signed by the provider by hand. So that way it comes out in the counterfeit proof paper. It looks much more legitimate. We know if it's going to be counterfeit or not if they try to photocopy it. Yes.
The retail pharmacist receives this voided paper. What do they do?
Probably throw it out. Probably, I don't know if they call the police, but I'd probably say this is no good. I'm not going to fill it. Yeah, and then just chuck it because they might try to go peddle it somewhere else. But yeah, if you saw that, I'd be like, no, I'm not going to do that. You'll find some pharmacists just won't fill C2s at all. They can be particularly persnickety about that sort of thing. So getting C2s filled can be really problematic. So especially once hydrocodone went to be a C2, that can be a problem for a lot of our peds patients because, again, we have a lot of kids who get outpatient surgery being done. They get their tubes placed or they get TNAs and things like that. They get sent home. They used to write for HiSet, which is hydrocodone and acetaminophen liquid. You could find that pretty much anywhere, right? Well, once it became a C2, you have more strict requirements on the prescriptions, and then if the mom was in a lot of places not necessarily carry HiSet because it's a kind of a pediatric specific drug, but the mom would have a script. She'd call it the pharmacy and say, hey, do you have this drug in stock? No pharmacy is ever going to tell you yes, they have a drug in stock like that, controlled substance, because they assume you're going to come rob them, right? So because of that, you say nope, we don't have it, and then the parents never find the med, and the kid is in pain, right? So that's why we had had to make sure that we were specifically stocking a lot of that in our pharmacy, actually in the hospital, so we can go ahead and provide for them. But that is a problem that you kind of run into in some cases. But other kind of good prescribing practices are to avoid abbreviations wherever possible. A lot of these can be mixed up and misconstrued for other things. So for instance, you don't use the term QD anymore because QD stands for once a day. But what does that get like potentially? Yeah, maybe QID, QOD, could look like OD. All of a sudden you have something like going in the eye, right? So QD went by the wayside. So instead you write daily or once daily, whatever it happens to be. Things like, if you write in the microgram with the actual, the mu symbol there, you end up getting that mixed up as milligrams. So we don't like that. So MCG for micrograms is what we like to write out. So again, fewer abbreviations, the better off you're going to be. A lot of cases, like the electronically done prescriptions, are going to avoid a lot of these anyway. So it's kind of nice because they'll automatically do it for you. But again, I like to avoid these mix-ups whenever we can. Best case scenario, we call you up and have to get clarifications. Worst case, patient takes it incorrectly and then they have toxicity from this. I always like to make sure we include strength and dosage forms on the prescriptions. So a lot of things like valproic acid has lots of different strengths, lots of different dosage forms that are available. We want to make sure we get the right thing that you intended for your patients. So that can lead to errors in some cases. Never write in teaspoons or tablespoons. Because again, if you go to, like, my IKEA spoons are going to be a lot different than like my spoons I get from the Chinese food place, right? Who knows how many mLs are actually in there? And again, a teaspoon is how many mLs? Yeah, it's 5 mLs is 1 teaspoon, and then tablespoon is 15. Yeah, so again, we don't like to dose in that because you get just a lot of room for error with that. So we always dose in mLs. You know, we will supply dosing syringes for the patients, that way they can draw it up and get exact amounts. And so the more we talk in mLs to the patients, the more they're going to be savvy with that and less likely to have errors with teaspoons and tablespoons. Never use trailing zeros, so never write 5.0 unless there's something after the O. That can be misread as 50. Again, tenfold error there. And never, always use leading zero. So, and that's actually an error that I did right there. You could have misconstrued that 0.1 as 1. So I made a boo-boo there. It should be 0.1. So always use your leading zeros, because otherwise it can be misread. Again, another tenfold error. Even I am fallible, as it turns out. Okay. We always like to include the quantity of drug. So again, it's just calculated by doing how many pills or the dosage form they're taking per day multiplied by the day's supply. Include that so that way we can make sure that what you guys are writing for actually makes sense and the patient's getting enough drug just enough drug to cover what you're treating and not too much or too little. If you ever want this actual brand name drug to be dispensed, you have to write DAW, which stands for dispense as written. Okay, so if we ever see that, Florida law says that if you write a brand name drug on a prescription and we get it at the pharmacy, we will substitute it for a generic if we can, because it's a cost savings for the patient. If you want the actual brand name, you have to write DAW. Obviously, if there only is a brand name available, that's what we're going to use. But if there's a generic, we'll try to switch that out wherever we can. Okay, so that's one thing to note. And then always, we really prefer it if you include indications, because this helps to make sure that, medications make sense, make sure other things on their profile make sense with what you're using it for. It helps to clarify instructions for both the patients and for the pharmacist. It helps to make sure that we can confirm kind of that clinical appropriateness. That's one of the things I hated about working retail. I only did kind of limited stint there, during like internship and things like that. But essentially, like I didn't like not having the full picture. I didn't like not knowing like what other medications could this patient be taking, or what was the doc thinking when they prescribed this. I actually being in the hospital where all those decisions are kind of made and I have the full picture. So whatever you can do to help your pharmacist out is going to be useful. And then other things that help keep those pesky PharmDs from calling you up, because no one likes a phone call from these guys. Review the patient's med profile prior to prescribing to make sure there's no kind of antagonistic combinations. Make sure there's no duplicate therapies. Make sure there's no allergies we're going to run into. Make sure if a patient is not supposed to be taking medication anymore, that they're not actually still taking it, because that happens more frequently than you might think. Make sure things are legible if you're going to be handwriting anything. And then make sure you're writing within the scope of your practice. So if you're writing as a dermatologist for ADHD meds, that's going to be looking a little fishy, right? Podiatrist is writing for phentermine for weight loss, that's looking a little fishy. So keep that in mind. And then if you guys have any questions about writing prescriptions, you guys are going to be experts by the time you get out. Not really, you guys are going to screw up a whole bunch, but that's okay, it's all part of learning. A good example, though, I did a site visit yesterday with one of your upperclassmen, and we was in a peds office, and so she did her case presentation, and at the very end of it, she was prescribing Tylenol as needed for pain. So I said, okay, well, how'd you figure out the dose and everything? And so she was like, well, I was really confused because they have these sheets where they say like this kid aged from 4 to 6, and then 6 to 8, and all this, but the kid's like he was 8 years old, but he's like 100 pounds already. So he's a very big kid. He's outside of the age range or the weight range for what that age should have been, right? She's like, I wasn't really sure what to prescribe for. Should I do it in the 8-year-old range, or should I do it based on his actual weight? And so, based on the peds lectures, what should you guys do? Based on the actual weight. So she ended up actually underdosing the child. Obviously she was not actually writing the prescription, but she was actually ended up underdosing based on that, just because she was going off of the age of the patient, not the weight. But again, we did the whole dosing calculation to figure out how many mLs the patient should actually get and all of that. And so again, it will come up. I'm not just teaching it to you because I like to make you guys do math, practical skills. Anyway, so any questions? All right, if not, I will see you guys Tuesday. We'll do a review, and then we'll maybe not have class Thursday. I got to make sure I get the blessing from the higher powers to do that, because I got nothing else for you. All my information's gone. Okay, I'll see you guys next time.